Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I'm your host, Amanda Mixon, and I'm thrilled to have you with us today. Whether you're listening on your way to clinic, catching up in between patients, or tuning in during some well-deserved downtime, we are so happy that you are here. Today's episode focuses on the foundations of PMR, which can be at times tricky, especially when it comes to distinguishing it from its mimics, initiating appropriate therapy, and one of the things that I find to be the most challenging, tapering steroids in a way that supports long-term remission while minimizing risks. To help us navigate all of these foundational issues and often nuanced topics, I'm joined by the incredible Heather Mambretti. Heather is not only a seasoned rheumatology provider, but she also is a passionate advocate for high-quality APP to APP education. Heather, thank you so much for joining us today. Before we dive into the discussion, would you mind introducing yourself for our listeners?
Sure, Amanda. Thank you so much for having me. It's a pleasure to be here. My name is Heather Mambretti. I've been a PA in rheumatology for the past 12 years, practicing in the Houston, Texas area. And my passion is for rheumatology care as well as teaching and retaining APPs in rheumatology. And I love precepting APP students.
That's awesome. I know. One of the first times I met you, it was at kind of a group in Houston. And I remember just, wow, you got all of these people to come, all these APPs to come for a journal discussion or something. And just how incredible that was. And I knew at that time, I'm like, I got to get this girl involved in RhAPP. And it's just been so awesome having you on this journey with me as a board director and just all the cool stuff that we've done with RhAPP.
Thank you, Amanda. I've really enjoyed it.
All right. Well, let's get into the discussion. So we're going to, again, be discussing the foundations of PMR. So let's just start with the basics. Can you tell me how you define polymyalgia rheumatica and what are the hallmark clinical features that should raise your suspicion in either primary or specialty care?
When I think of PMR, I think of the defining characteristics as it being an autoimmune disease that is typically characterized by achiness and stiffness in the pelvic and shoulder muscles, sometimes also the cervical region. It's actually the second most common rheumatic disease, second to rheumatoid arthritis. And I know that it can be associated with giant cell arteritis. In fact, there are theories that that is one of the two things on the same spectrum of disease. I think that most of the time when patients come into the office and there's a concern for PMR, they're describing to me kind of a freight train of malaise, achiness, and stiffness. And that's that sudden onset that really defines that process for me. There's also a criteria set with ACR and EULAR from 2012 that I think is helpful, but it's also primarily used in the setting of research. But the criteria from ACR and EULAR does include the strict criterion that patients be over the age of 50. They have at least 45 minutes of stiffness in the morning. Shoulder pain has to be involved, and they have to have elevation of CRP or ESR.
It's interesting. So, again, sometimes I will, sometimes this is kind of one of those, I don't want to say like easier diagnoses to make, but sometimes these patients can be so classic. Like they were, an elderly person, and all of a sudden they couldn't, tie their shoes. They couldn't get out of bed. They couldn't raise their arms. And, that mixed with the inflammatory markers being elevated is kind of like, okay, yes, we definitely have our diagnosis. Plus, of course, the steroids, which we'll talk about in a minute. But I always kind of enjoy these consults because I'll say to patients when I make a diagnosis of PMR that, this is the one disease or disorder that, eventually you're probably not going to need to see me anymore. Maybe you'll need to see me again, but not always the case. And so it is kind of one of those things that can be somewhat self-limiting, which I think is really good for patients to know that, hey, they're not going to have to be on medicines for potentially the rest of their lives.
I agree with you. I think when patients come in and start asking them a history of, and diving into PMR characteristics, I often see patients light up and say, oh my gosh, that's exactly what's happening to me. I thought I was just going crazy, but you're describing what I'm experiencing. A lot of times I'll ask them, are you having difficulty rising up from a chair or getting out of your bed or going to the bathroom and getting off the commode? Are you having difficulty raising your arms to do your showering or do your daily activities. And a lot of patients will not initially kind of clue into all of that, but they say, you know what, I really have had difficulty doing all of those things. And so I think patients are really reassured when you can describe to them kind of the classic PMR criteria that they didn't realize they were meeting.
Well, and on that same note, I mean, that's kind of your classic presentation, but what are some common diagnostic pitfalls or potentially mimickers of PMR that we should all be aware of?
So I think that some of the difficulty that I had, especially early in my career, was not doing an adequate and really detailed medical history. I think that can be a pitfall. Just the history of this disease is going to be your best tool. So really getting a detailed history at their first visit, even repeating that discussion at their second visit. And then also one of the pitfalls that I know I fell into is not doing somewhat of an extensive lab workup to rule out other rheumatic disease markers and other things. I think that the mimickers of PMR, in my mind, when I see a patient presenting with what I feel like might be PMR, would be other rheumatic diseases as mimickers. Rheumatoid arthritis or sometimes lupus presentation may mimic PMR, also dermatomyositis or polymyositis. Certainly patients can present mimicking PMR with fibromyalgia type symptoms or even underlying malignancy that they're not aware of in terms of like a paraneoplastic syndrome or different endocrine disorders. I've had patients with thyroid disorder that they didn't realize was happening and it mimicked the symptoms of PMR.
Yeah, I think to your point, I think doing that history is just the most important to really try to decipher when did it start? What are the other things that are going on? Do you have, a fever, night sweats, lymph node swelling, like trying to kind of think about some of the other things because you're absolutely right. As much as, yeah, it's awesome when we make this diagnosis and it's like, okay, great. We have our official diagnosis, but you certainly don't want to miss other things. And to your point, something, much more scary, like, vasculitis or, an underlying malignancy, which often has, really high markers of inflammation as well. So, it's just kind of thinking through that. Yes, common things happen common. And yeah, this is the second most common, rheumatic process that we're going to see. But we can't just be completely pitfall to say that that's definitely what this is until we do, a thorough history exam and then appropriate lab studies too. Because we certainly don't want to miss something else because we're going down, this one road.
Right.
So let's kind of talk about that initial workup. You have a patient that you see that, you suspect has PMR. What are the labs or imaging studies that you find helpful when you're supporting this diagnosis?
Yes. So initially, when I'm thinking about my workup for a PMR patient, I will not usually order imaging studies unless the patient presents with classic PMR symptoms as well as perhaps some peripheral synovitis or inflammatory joint pain. In that case, I may order peripheral x-rays, joint x-rays. I know that in some settings, ultrasonography can be helpful in identifying bursitis and things like that in terms of inflammatory findings, but I'm usually not ordering that. From a lab monitoring or lab evaluation standpoint, I will always order basic serology such as ANA with cascade reflex, as well as rheumatoid factor and CCP antibody. I will also usually check CBC, a complete metabolic panel, as well as definitely sedimentation rate and C-reactive protein for every patient. And then in those patients where I'm considering ruling out other mimickers, I may also add thyroid stimulating hormone or serum protein electrophoresis.
Yeah, I do the exact same things that you do. And, hopefully, again, your history and your exam will help guide you. Like, is there anything that looks like vasculitis? Because, of course, then you might consider an ANCA. But, I certainly wouldn't recommend just ordering ANCAs just because, because that can definitely take you down a road maybe you don't need to go down or want to go down. But, yeah, I do the exact same thing. It's kind of like really listening to the patient, hearing what they've said, and then, ordering those appropriate labs. And I also don't do imaging. Sometimes patients come with, because maybe they've been dealing with this for a while and maybe they've been sent to orthopedics and they'll have had an MRI of their shoulders already. And maybe it'll show a subacromial bursitis. which is kind of one of those classic things you see with PMR. But truly, yeah, imaging doesn't tend to help you because it's mostly going to be normal. You're not going to see changes of like rheumatoid arthritis or things like that. So, again, sometimes patients come with it, but I'm with you. I don't typically order that unless there's some additional reason. Yeah, they have inflammatory arthritis in their hands, et cetera. So yeah, that's exactly what I do too. Can you walk through some of your typical strategies for initiating therapy, specifically when and how you start glucocorticoids and what your goals are for the first few weeks?
Sure. So when I see a patient who is presenting with possible PMR, I will start a prednisone, typically 15 or sometimes 20 milligrams per day at that initial visit. And ideally, I will call the patient within 3 to 5 days just to follow up with them. And what I'm looking for there is a dramatic response to steroids. And usually when I'm calling patients to check on that initial first few days of response, the description they are giving me is like night and day difference. I can do the activities I was struggling with. Sometimes patients will come in for a rheumatology consult already on prednisone, sometimes even on a high dose of prednisone, maybe from a primary care or urgent care setting. I've had patients come in with as high as 40 or 60 milligrams a day of prednisone, and patients are already feeling better. At that point, though, I will, taper them down to a 15 to 20 milligram dose. And my initial goal is to keep them at a dose of steroids where their symptoms are resolved for basically 2 to 4 weeks before I consider tapering those steroids. Now, I will say in those patients who have, let's say, comorbidities like uncontrolled high blood pressure, or especially type 2 diabetes, my starting dose of prednisone in those PMR type patients with underlying comorbidities is sometimes 12.5 milligrams per day, just in consideration of those other issues they're facing. The goal that I have the first couple of visits is to establish a really good rapport with the patient. I want them to feel like the expectation is set for them to be seeing me every 4 to 6 weeks while we're managing, the initial dosing of steroids as well as the tapering process. And then I set the groundwork for understanding the goals of tapering steroid therapy to minimize the side effects and the potential that we may need medication on board for steroid-sparing capacity. So I set those expectations at my first couple of visits as I'm initiating steroids.
I think that's really smart, because again, it's like steroids are the drugs we love and hate, right? Like patients love to be them. You're absolutely right. This is one of those diagnoses that when you start to make, people love you because they couldn't walk and now they're walking. I mean, it's so incredible. And, and they feel good and they're able to do the stuff that they want to do again. But you're right. It's challenging. It's really challenging. You're right. When people come in on like high doses of steroids and then we're trying to figure out what really the diagnosis maybe was or is, and, how we obviously taper the prednisone effectively. I do the exact same thing, 15 milligrams, if they have comorbidities, which unfortunately a lot of times patients in this, they're older patients, they often do have comorbidities. So that's always a challenge. But yeah, I kind of do the same thing, 15 for the first, month. And then maybe 20. It just kind of depends on the person, and then kind of this slow taper. And this is really the art of medicine. I've asked people over the years, like, well, how do you taper? Well, how do you taper? It's really different based on the provider. And obviously for us as APPs, we probably do it based on how our mentors did it. And my mentor did 1 milligram, every month. And so that's kind of what I do. I get down to 10 and then I decrease by 1 milligram a month. But everyone does it a little bit differently, of course.
That is so true. I will say that every rheumatologist I've ever worked with has had a different art of tapering steroids. So I've tried several methods, and it really that gestalt of, okay, this patient's going to be able to taper a little more quickly. I typically lower, if I'm at 15 or 20 milligrams a day, I will lower the steroid tapering by 2.5 milligrams every 2 to 4 weeks until we get to 10 milligrams. And then I do reduce my tapering to maybe 1 milligram every 2 to 4 weeks. Mm-hmm. I do consider being more aggressive, though, if, again, patients have uncontrolled high blood pressure or diabetes or are already experiencing quite a bit of steroid-related side effects.
Yeah, absolutely. I do the same thing. I'm like, okay, now you can go down by 2.5 this next month. And yeah, for sure. It's different. It's all different. But we know the important things I think to remember are don't start too high. You don't often need 30, 40, 50, 60 milligrams of prednisone. No. And if you do, you probably have the wrong diagnosis. And then just kind of that slow taper and kind of also understanding with the comorbidities. So on that same realm, what are some red flags or signs during your taper that you might, say, I wonder if I'm dealing with actually PMR or something else? How does that look for
Sure.
you?
So again, exactly what you mentioned. If they're not responding to 15 or 20 milligrams of prednisone, then this is probably not PMR. That's the first red flag that I'm looking for. Or, if they're unable to taper below even 10 milligrams of
Yep.
prednisone without symptoms recurring, I'm kind of considering, is this the correct diagnosis? If they have escalation or new evolution of other systemic symptoms while we are tapering prednisone, then I have to think, all right, revisit the initial diagnosis. And then certainly I'm also looking at the same time, every follow-up visit for a patient with PMR, I'm carefully evaluating, could this be someone who may also have developed symptoms of giant cell arteritis? I'm asking them every visit when I'm checking them at PMR follow-up, have you had vision loss or jaw claudication symptoms, temporal scalp pain or headaches because of the association of GCA in patients with PMR?
Absolutely. That's so smart. I'm so happy you brought that up because, there are very few rheumatologic emergencies, and obviously that is one of them. So always asking those questions just because of that correlation. I do the same thing. Again, it can be a little bit tricky just because, they're already on steroids, but obviously getting that biopsy is crucial because then you obviously do need much higher doses of steroids. Right. And I'll tell you, I've had a patient, I can think of one just in the last couple of months where this gentleman came in. And of course I was thinking, oh yeah, this is PMR just based on what he was describing. And then I start asking those questions like, well, yeah, as a matter of fact, I've had this left-sided temple pain. And I'm thinking, oh gosh, and that was right at the very beginning. And so then it was like trying to get this, biopsy done ASAP, which fortunately I was able to do, because it totally guides you. It totally guides you on how much steroids, on steroid sparing, all of those things. But yeah, I do the exact same thing. Like if they're not responding or if I'm needing to bump higher, then I'm reevaluating the diagnosis. Or do they have something else, right? Like do they have, again, concomitant, whatever it might be, because you can have more than one thing. So that can also be challenging. But that's also, if I have a patient that every time I get them to 5 and, then they're bumping it back up to 10, of course, then I'm also thinking about some of our steroid sparing options as well. Patients love steroids, of course, because they feel better, but there are risks. So how do you discuss these long-term steroid risks with your patients, and what strategies do you use to try to mitigate those risks throughout your treatment?
That's such a good question. And I think it's so important because as you mentioned, as we were talking about, patients feel wonderful on 10 to 15 milligrams of prednisone. And I think I try and set the expectation and just the understanding up front. What I learned and what I tell patients is P is for poison. Prednisone is really bad for you over the long term, especially at medium high doses. So I explain to them at every follow-up visit, our goal is to use prednisone in necessity time, but we have to get you off of this because it's going to cause you to have cataracts. That's going to elevate your blood sugar and your blood pressure. It's going to cause you to gain weight. You're going to have skin integrity issues, even GI ulcer risks and infection risks. And when patients and I start talking about, if they've had difficulty with flaring of PMR as we are tapering steroids and they've really failed that tapering process, I tend to discuss at an early time maybe the use of steroid-sparing agents. I'll sometimes discuss our typical disease-modifying medications like methotrexate or leflunomide. However, I'm a really big fan of the only FDA-approved biologic in the setting of PMR, which is Sarilumab or Kevzara. I tend to use that pretty aggressively, especially in our patients who have comorbidities.
Yeah.
So, for example, my diabetic patients who also have PMR, when I'm like really anxious to get them off of corticosteroids, I'm often initiating Sarilumab after they've failed their first, they had a first relapse after a steroid taper attempt. And the way I talk about that with patients is, I explain risk and benefit of Sarilumab, and they're often concerned about risk of infection. But I remind them that a dose of chronic 10 to 15 milligrams of corticosteroids is also putting them at high risk for infection, in addition to all these other side effects. So I mitigate their risks by talking to them about early initiation of steroid-sparing medication. I do lean heavily on Sarilumab as the only biologic, and I've had really good success. I probably have maybe 15 or 20 patients in our office who have started Sarilumab, and the experience that I have had clinically is that within 12 weeks, my patients are off of steroids and not flaring. And, thankfully, I have had few difficulties with getting medication access for patients, and they've done really, really well. And the other things I will do to mitigate risks of steroid side effects would be to place some patients on proton pump inhibitor for extra GI protection. And then I also start using screening methods to make sure I'm assessing their bone density status and then initiating treatment early if they're low on bone density. And I know we're going to have them on steroids for a period of several months. And then I'm also trying to coordinate pretty closely with their primary care physician and their other specialty medical providers, so that if they do have other conditions that are going to be aggravated or just intensified by corticosteroids for a time, they can manage their diabetes and their high blood pressure, other things closely while we are handling the PMR.
Absolutely. I do the exact same thing. I mean, it's so nice that we have other options now. And I've also had really good luck with Sarilumab as well. So, I totally agree with you. And then working with the primary care, reminding them that we are not their primary care. They really do have to work with them, staying current with all of their preventative medicine, is so, so crucial. And absolutely right. Getting that bone density is really important too, especially at the get-go, because if this person is already osteoporotic and you're starting them on steroids, you're not doing them any favors. And so really getting on top of all of those things and diabetes monitoring, all of that. So, I do the exact same thing, and it makes me feel good that I know somebody else is doing the stuff that I'm doing. And that I'm doing it the right way. Because even, after this long, you still want to make sure that you're, doing what you should be doing, right?
It's nice to know that your peers are following a similar process and that you're kind of all on the same page. I will say one of the things that I have learned from some of my APP peers is the importance of, during the PMR monitoring and steroid tapering and even Sarilumab initiation process, I think it's really important that we keep close follow-up with these patients, because I don't know about you, Amanda, or maybe someone listening to this, but my experience is that with patients who have PMR, sometimes they do strange things with prednisone. Even after their follow-up visits, I have taken to in the habit of writing out a prednisone tapering schedule. Even though we're talking about it in detail, I will write it down for them. And sometimes, even despite best efforts and the patient's really trying to do what they think is right, they'll misunderstand and they'll come back and I'll realize they're on a totally different dose of prednisone than what we talked about. So I see these patients every 4 to 6 weeks, and every time I am giving a written list of instructions on what to do with prednisone, and I tell them, call me, send a message to the office. If you're having a flare or you don't know what to do, please don't willy-nilly adjust the prednisone until we talk.
Oh, that's such good guidance. I totally agree. And this is an older population. They're not often tech savvy. Sometimes they can't, go into the portal and things like that. But so that's so important to write it out. Although it just reminded me, like when my grandmother was still alive, she was 96 and very heavily involved on Facebook. So I don't know. I guess it just depends on who it is. But, well, thank you so much, Heather. You're obviously so smart and you take such good care of your patients. And I really do appreciate you spending the time with us today.
Thank you so much for the opportunity to share with you and to dialogue about PMR.
Of course. Well, that brings us to the end of the episode of RhAPPcast. Again, a huge thank you to Heather for sharing her time and expertise on management and diagnosing PMR. Before we sign off, please don't forget the RhAPP National Conference is right around the corner, happening September 25th through 27th in beautiful Denver, Colorado, my home. This year promises to be our biggest and best yet, with 3 full days of cutting-edge education, hands-on learning, and community building.
I'm so excited to see you there.
Oh, I know. It's going to be so exciting. I really think this one is going to be our best yet. Just a few standout sessions that we're doing this year, which is different, is our IMID and obesity boot camp led by a dynamic multidisciplinary team. We also are doing an ILD boot camp, which features small group-based discussions designed to level up your skills in managing complex patients, as well as some of the ones that you obviously have come to know and love. The ultrasound boot camp with Nate the Great, I think is what we call him, is always a hit, and lots of other new things too. To stay in the loop on all things RhAPP, please follow us on X and Instagram at RheumAPP and connect with us on LinkedIn at Rheumatology Advanced Practice Providers. Thanks again for tuning in. I'll see you next time.